So the body resort to carry on with
Thank you, Kanchana, for those kind introduction. Today I'm going to talk on tackling the burden of CKD in primary care. As we all know, CKD is a major health problem, and the treatment of CKD and end-stage renal failure is a very costly. So it is important to reduce the burden of CKD. So my talk is going to be based on these lines: definition of CKD, then I will talk about epidemiology and risk factors, and prevention and early detection, and management of CKD, and the impact of AKI on CKD. So the CKD is defined by abnormalities in kidney structure or function assessed using a matrix of variables. Those variables are glomerular filtration rate, as we estimate glomerular filtration rate using serum creatinine, and other matrix is urinary abnormalities, the presence of albuminuria or proteinuria. So based on these, we classify CKD using this grid. So we have two variables. One is the glomerular filtration rate. With the glomerular filtration rate, we categorize CKD from G1 to 5. In addition, other variable we measure is the albuminuria. Depending on the albumin excretion, we categorize from A1 to A3. And there are, you can see the boxes, the green, yellow, orange and red. So what does it indicate is the risk of progression towards end-stage renal disease. So if you are in early stage of CKD with minimal albuminuria, your risk of progression is very low. Whereas if you are having advanced chronic kidney disease or having increased albuminuria, or both, your risk of progression towards end-stage renal disease is very high. So if you look at the prevalence of chronic kidney disease across the globe, it is in the range of 10 to 15%, depending on the screening method you use. The high prevalence is seen in Europe and US, probably due to the older population, because the elderly have a high risk of having CKD because of with the age there's a decline in chronic GFR. But right across the globe it's around 13 to 15, 16%, stage 1 to 5. Whereas if you take stage 3 to 5 CKD on your right hand side, it is again the range of 8 to 12%. So the prevalence of CKD is fairly high and it is right across the globe. However, if you look at the prevalence of end-stage renal disease, there's a big difference. If you look at this picture, the developed countries like Japan, United States and many European countries have a high prevalence of end-stage renal disease, whereas developing countries like South Asia and Africa have a low prevalence of end-stage renal disease. Why? What's the reason for it? Although the prevalence of CKD is almost the same, the prevalence of end-stage varies because in developing countries where the facilities resources are limited, most of the patients die with end-stage renal disease because they don't get renal replacement therapy or they get inadequate renal replacement therapy. Whereas the developed economies, they have enough resources, so they live or they survive on adequate dialysis. So that's the reason why the prevalence is varies. So if you are in a poor country, you will die of end-stage renal disease. If you are in a rich country, you will live with end-stage renal disease because the cost of the treatment is pretty high. That's why we have to prevent the development of end-stage renal disease. So if you look at what happened to patients with chronic kidney disease, and it is a progressive disease, and there's a progressive decline in GFR, and the patient will reach end-stage renal disease. That's one thing that could happen to a patient with CKD. And other thing is the patient with CKD have an increased risk of developing cardiovascular disease, so they can develop cardiovascular complications and they can die of cardiovascular disease. And the other thing is the chronic kidney disease patient, they develop certain complications like anemia, bone disease, and so on. So that also can occur when you are having low GFR. So if you take 100 patients with CKD stage 3, where the GFR is less than 60 ml, when you follow them up for 10 years, and 65 of them died of cardiovascular events. So most of the people died of cardiovascular disease, and 10 patients would be in renal replacement therapy. So out of 100, 10 reach end stage and they are on dialysis. 25 would be having ongoing CKD. They will be having CKD pre-dialysis stage. If you look at the causes or etiologies of CKD, large chunk, it's about 42%, is due to type 2 diabetes. So type 2 diabetes is a major contributor to the chronic kidney disease, followed by high blood pressure. It's about 28%. Then other diseases like glomerular disease and type 1 diabetes comes fairly low. So major contributors are type 2 diabetes and hypertension. If you properly manage these two conditions, you can actually reduce the burden of CKD. And these are modifiable. So if you look at the risk factors for CKD, there are modifiable risk factors and non-modifiable risk factors. Diabetes, hypertension, AKI. So AKI is one factor that lead to chronic kidney disease. So, and the frequent use of non-steroidal anti-inflammatory drugs. So these are modifiable risk factors. And family history of diabetes, hypertension, and kidney disease, old age, and certain race group. These are non-modifiable risk factors for chronic kidney disease. And this graph shows the United States renal data with the increasing number of diabetes and hypertension are the major contributors to chronic kidney disease. And as I mentioned, many people with chronic kidney disease develop cardiovascular disease, and this particular study shows the risk of coronary events in people with chronic kidney disease compared with those of diabetes. So if you don't, on your right hand side, you see if you are not a diabetic, not a CKD, your risk of developing coronary event is very low. If you are a diabetic, you have fairly high risk. If you have a chronic kidney disease, even higher. And if you are a diabetic and chronic kidney disease, you have very high chance of developing cardiovascular disease. So this is again the same thing is in a different way. So the diabetes and chronic kidney disease contribute to the cardiovascular disease. And if you are a diabetic and CKD, you have very high chance of developing cardiovascular disease. You can die of cardiovascular disease. So cardiovascular disease is a major cause of death in patients with chronic kidney disease. And what about the cost, healthcare cost? So healthcare cost is very high in patients with CKD. So with this is again data from United States renal data system. The cost of the healthcare cost is increasing in billions of dollars as the number of patients with chronic kidney disease is increasing progressively. The healthcare cost is increasing. Then again, this is again a per person per month expenditure. So if you are a patient with chronic kidney disease, a pre-dialysis stage, your cost per month is about $5,000 or less than $5,000. But when you reach end stage and when you are on renal replacement therapy, your expenditure is increased to about $20,000, right? So, the care of end-stage renal disease is very costly. So, therefore, preventing progression of CKD will help to cut down the healthcare cost. So, how do we screen and evaluate for patients with chronic kidney disease? So, this is a study shown the CKD screening in primary care, and 50% of the patients are not screened in primary care, right? Because the patient with diabetes and hypertension are the major contributors, and they are followed up in the medical clinics or by the general practitioners, but they are not screened for CKD in most of instances. And about 30% of the time they are tested, but there is no appropriate diagnosis of CKD is made, and only it's about 10-12% of patients are tested and diagnosed as having CKD. And studies demonstrate that the clinician behavior changes when CKD diagnosis improves. And there's a significant improvement realized in increased urinary albumin testing and increase and appropriate use of AC inhibitor or angiotensin receptor blockers in the management of hypertension and CKD, and the avoidance of non-steroidal anti-inflammatory drugs prescription among when there's patient with low GFR, and they are referred for nephrology consultation at an appropriate time. So how do we screen for the patient for CKD? So the most important screening tool is an estimated GFR. It is considered the best overall index of kidney function, and the normal GFR varies according to the age, sex, and the body size, and there's a natural decline in the GFR with age. After the age of 40, there's a decline of GFR by 1 ml per minute per year. And the National Kidney Foundation recommend using the CKD EPI creatinine equation, which is developed in 2009 to estimate the GFR. So we don't actually measure the GFR because it's a cumbersome procedure. So we check the serum creatinine by the standard method, and we use this formula to calculate the estimated GFR. And there are other calculators also used using, there's an MDRT equation and the Cockcroft and Gold formula. So there are these calculators available online, so we can download it and save it in our smartphones, and whenever we come across a patient, if the laboratory has not given the estimated GFR, so we can, using the app, we can calculate the GFR. So thereby we can classify these patients, whether the patient have CKD or not, and also we can tell whether the patient, what stage of CKD the patient is in. So other screening tool is the albumin to creatinine ratio. So urinary albumin to creatinine ratio is calculated by dividing albumin concentration in milligrams by creatinine concentration in grams. So the creatinine assists in adjusting albumin level for varying urine concentration, because the urinary albumin concentration varies according to the time of the day and depending on your fluid intake. So to correct that only, we check the creatinine and we divide the albumin by 2 creatinine. So this allows a more accurate result versus albumin alone. The spot urine albumin to creatinine ratio frequently used for quantification of albuminuria. So according to the guidelines, we classify them as mild, moderately, severely increased when they depending on how much the albumin excretion is. And we use the first morning void sample is preferred. Therefore, the 24-hour urinary testing is not necessary, because it's doing a 24 urine collection is a cumbersome procedure. So by doing a spot urine albumin to creatinine ratio, we can detect chronic kidney disease. So when you have the urine albumin to creatinine ratio and the estimated GFR, uh, we can categorize them into well, they are in what level of CKD they are in. So the criteria for diagnosis CKD, again, abnormalities of kidney structure or function persisting for more than 3 months with the implication for health. This Either of these should be present for more than 3 months. The albumin to creatinine ratio more than 30 milligram per gram, or if there's any marker of kidney damage, or GFR less than 60 ml per minute. So this again, and so when you do know the GFR and albumin excretion, we can using this grid, you can categorize the patient into what is the level of CKD and what is the risk of the patient progressing to end-stage renal disease. So how do we manage this patient with chronic kidney disease? So the main aim of the management of CKD is slowing or stopping the decline of kidney function. So in order to do that, the blood pressure control is very important. And the blood pressure target varies depending on the albumin to creatinine ratio. And if your albumin to creatinine ratio is less, your target is less stringent, less than 140/90. Whereas your albumin to creatinine ratio is high, you have a more stricter blood pressure control is required. It is less than 130/80. And individualize the target and agent according to the age, coexisting cardiovascular disease and other comorbidities. Our first choice is either AC inhibitor, angiotensin receptor blockers, because these agents not only control blood pressure, it also reduces the albuminuria more than what you expect for the blood pressure control. But one word of caution, the using AC inhibitor or ARB in elderly and medically fragile patient, because they can have undiagnosed renovascular disease as a cause of their CKD. So when you use AC inhibitor or ARB, the creatinine can increase due to the presence of renovascular disease. So therefore, when you start a patient on AC inhibitor, you should have a baseline creatinine, and you should repeat the creatinine in about 10 to 14 days. And if the serum creatinine is expected to rise in many patients with the use of AC inhibitor, but the increase is less than 25%, it is you can still continue the AC inhibitor. You don't need to stop, but you continue to monitor the creatinine. So what happens is that there is a small rise in serum creatinine, which is stabilized thereafter. It will not continue to rise. But if their creatinine rises more than 25% after starting AC inhibitor or ARB, then it suggests there is an underlying renal artery stenosis. And in these patients, you should stop. Otherwise, they will continue to the patient's creatinine continue to rise, and they would require dialysis. So, if there is a more than 25% increase, you should stop AC inhibitor and evaluate this patient for the presence of renal artery stenosis. And there is no particular cutoff of EGFR for the use of AC inhibitor. You can use as long as there is no contraindication. But when the patient has an advanced CKD, the patient's the potassium can go up, and you may have to stop it. And so when you use AC inhibitor or ARB, there is a proteinuria gets suppressed, but the proteinuria suppression is better if you use a low sodium diet and diuretics. So it will enhance the low sodium diet, and diuretics enhance the effect of AC inhibitor or ARB. But however, we should avoid volume depletion, because when a patient is on AC inhibitor or ARB, when they have volume depletion, there is a risk of developing AKI. And we should avoid the combination of AC inhibitor ARB, because there is an increased adverse events like impaired kidney function and hyperkalemia. So we should not combine these two agents. So So another important aspects of slowing down the progression or arresting the progression of CKD is glucose control. As I mentioned before, the major contributor to CKD is diabetes, and a patient with diabetes and CKD have a good blood glucose control. The target HbA1c is less than 7, um, but the target is varies depending on the comorbidities, age, and the risk of hypoglycemia. And the risk of hypoglycemia increases with the kidney function, renal function decreases. So the target of glycemic control should be individualized, and HbA1c to 6.5 to 8 depending on various factors. So if you are a patient, if your patient is early stage of CKD and the patient has fewer micro and microvascular complication and comorbidities, younger age, and the patient has hypoglycemic, he has the resources to manage hypoglycemia, and he has a hypoglycemic awareness is there, then you can have a very stringent target like 6.5. But if your patient is having advanced CKD, has a many micro and macrovascular complication, elderly, and has a short life expectancy, has absent hypoglycemic awareness, in these patients, you should have a higher target. So you have to a particular patient, you should have a target, and we should try and achieve that particular target by using any agent. And the metformin is the first line of treatment patient with type 2 diabetes and CKD when the GFR is more than 30 ml per minute. And some of the general practitioners make a mistake because as the metformin stopped when the patient has a CKD, even when the patient with a normal serum creatinine with increased ACR, when there's microalbumin positive, some do stop metformin. So it is not good. So the metformin is the drug of choice for the type 2 diabetes and CKD, and it is the first line, and it can be used until the GFR is below 30 ml per minute. And one has to monitor the GFR while on metformin, and we have to adjust the dose of metformin according to GFR. When the GFR is less than 45, we half the dose of metformin, and when the GFR is below 30, we stop it. And one has to monitor the vitamin B12 deficiency when the metformin is used for more than 4 to 5 years. And as I mentioned, we discontinue when the GFR is less than 30, and it has to be discontinued when there is a AKI, critically ill, or contrast use. So during these instances, metformin is temporarily withheld. And other important the oral hypoglycemic agents, SGLT2 inhibitors, and the metformin and SGLT2 inhibitors are the drug of choice, should be according to the latest guidelines when a patient have diabetic kidney disease. So if your patient has a diabetes and albuminuria, so when we label it as CKD or diabetic kidney disease, they should be on metformin and SGLT2 inhibitors, because in addition to the glycemic control, SGLT2 inhibitors give a renal protection, because when the SGLT2 inhibitors work at the proximal tubule, in addition to glycosuria, we have a natriuresis, and these, because of the increased sodium in the distal convoluted tubule, it is sensed by the macula densa, and it in turn causes vasoconstriction of the afferent arteriole, whereby it reduces the intraglomerular pressure. So this is how the SGLT2 inhibitors give an additional renal protection. So when you look at the diabetic kidney disease pathogenesis, on your left hand side you see the normal glomerular microcirculation. When there is a diabetes, the afferent arteriole is dilated and the efferent arteriole is constricted. Thereby, there is an increased intraglomerular pressure, which in turn causes albuminuria or proteinuria. So this is how the diabetic kidney disease occur. So when we use SGLT2 inhibitors and the renin-angiotensin system blockade, these hemodynamic changes is restored to a certain extent. So when a patient has diabetes or CKD, the afferent arteriole is dilated and efferent arteriole is constricted. So when you use renin-angiotensin inhibitors, either AC inhibitor or angiotensin receptor blocker, your efferent arteriole is dilated. When you use SGLT2 inhibitors, the afferent arteriole is constricted. When you use both combined AC inhibitor or ARB and SGLT2 inhibitor, you are almost restored the hemodynamic changes that occur due to diabetes. These are the key in the management of early diabetic kidney disease. So the next important aspect is as I mentioned earlier, the cardiovascular disease is one of the most common complications in patients with CKD. So therefore, every effort should be made to reduce the cardiovascular risk factors like smoking cessation, exercise, maintaining an ideal body weight, and lipid lowering drugs. And when the GFR is more than 60, the statin and ezetimibe combination statin, or when the GFR is less than 60, the statin and ezetimibe combination gives it has been shown to be cardiovascular protective in many studies. And aspirin is indicated for a secondary prevention but not as a primary prevention. Right. So the next the step in the management of CKD is to detect and manage CKD complication. The CKD patients develop some complications when the GFR goes below 50-45. So one of the most common complications is anemia, and they have both the anemia is the major contributors to anemia is iron deficiency and erythropoietin deficiency. So we check the iron deficiency by doing transferrin saturation and serum ferritin. When the transferrin saturation is less than 30% and the ferritin is less than 500, we give intravenous or oral iron. So in dialysis patients, we give intravenous iron. In non-dialysis patients, CKD patients, we usually give oral iron. And so once the iron stores is corrected and still the patient is anemic, the hemoglobin is less than 10, we start erythropoietin stimulating agents like erythropoietin or dabapoietin to maintain the hemoglobin around 11 to 12. So the appropriate iron supplementation is required to use these erythropoietin stimulating agents. Otherwise, your erythropoietin will not work if you are iron deplete. The other important complication is the mineral bone disease. So most of the patients, we have to check their vitamin D levels, and the vitamin D levels are low. We have to use vitamin D supplements, either 2000 IU per oral, or we can use either monthly dose. In addition, we have to cut down their phosphorus in diet, because one of the other important complication they'll have is hyperphosphatemia. So we have to correct the hyperphosphatemia by limiting the phosphate in the diet and also use a phosphate binding agent. And other complication is the metabolic acidosis is fairly common, but it occurs in advanced stages of CKD. So in patients who have CKD and metabolic acidosis when the bicarbonate is low, we use sodium bicarbonate supplement to keep their bicarbonate level more than 22. And metabolic, because by correcting the acidosis, their functional state improves. And hyperkalemia is another complication when the GFR is declining, particularly in advanced stages. So we have to reduce the dietary potassium intake, and other drugs that could increase the potassium in CKD patients are NSAIDs, COX-2 inhibitors, and potassium-sparing diuretics, and these agents should be stopped. And also the AC inhibitor and ARB also increase the hyperkalemia, but we do use them with caution. And also we have to avoid potassium supplements. And it is important, we have to pay attention to the nutrition. There are many things we have to pay attention to. One of the important things is the sodium restriction, because most of the patients with CKD are hypertensive, and also high sodium diet promote increasing the proteinuria. We have to limit the sodium intake. We have to cut down the fat intake because the cardiovascular complication, and we have to give adequate calories. And the protein restriction is important. We advocate moderate protein restriction, because moderate protein restriction slow down the progression of CKD. And we also pay attention to the phosphorus in the diet. We have to limit the phosphate in the diet. Most of the animal protein and milk products contain phosphate, so they have to cut down the phosphate intake, and also they have to limit the potassium intake. Then how these patients with the CKD are followed up. So most of the patients with the stage 1, 2 and 3 CKD are followed up in the general clinics, either general medical clinics or by the general practitioners, or there are other specialists. So it is important to know that they have chronic kidney disease, because then only we can take appropriate safety measures. Because when the patient has reduced GFR, we have to make sure that their diet has to be balanced, and they should avoid certain medication. So it is important that the general practitioners and other physicians should aware of the changes that need to be prescribed for the patient with CKD, because most of the patients are followed up by non-nephrologists. And of course, when the patients come to stage 4 and stage 5, they have to come under the care of nephrologists. So they will be followed up in nephrology clinic. So this is a slide. I want you to take a note how a careful approach will prevent the development of end-stage renal disease. Say, for example, if you have a patient, a 70-year-old with CKD stage 3 with a GFR of 40-45. So generally, these patients, the progressive decline GFR at a slower rate, around 2 to 3 ml per minute. So this particular person will not reach end stage in their lifetime. But if the patient is CKD is not known to the treating physician, or it is his CKD is overlooked, then what will happen? Say if a person has an attack of gout and treated with NSAIDs, and there is a decline in GFR, and this decline may not recover to original level. Then if a patient, the same person developed a coronary event and undergoing a coronary intervention without taking appropriate precautions, then again there's some more decline in the GFR. And if we get an abdominal sepsis and treated with aminoglycoside, there's a further decline. And then the patient is and get a episode of hypotension, and while taking AC inhibitor and diuretic, and develop a hypotension, and he will develop an AKI, and this patient will reach end stage in about 2-3 years time. So if you know the patient has CKD, and if you take appropriate precautions to prevent these episodes, then the patient will not reach end stage renal disease. So because as I mentioned before, treating end stage renal disease is very costly. So it is important that the patient CKD the GFR should be known, particularly when the patient has a risk factor for developing CKD, that is diabetes and hypertensive patients. So therefore, if you know that the patient has CKD, you can take appropriate precautions to prevent their progression. So the CKD patients have many safety issues. They can have medication errors because the so many drugs, particularly antibiotics and any other drugs, we have to adjust the doses for the level of GFR. So if you don't know the GFR, you may end up giving higher dose. And also they can have electrolyte abnormalities. As I mentioned, hyperkalemia. They can have hypoglycemia, hyperphosphatemia, and also when you do the diagnostic test like iodinated contrast media, when you use, they can develop AKI. When you use gadolinium for MRI studies, when the GFR is low, they develop a condition called NSF, that is systemic fibrosis. And also the patient with CKD have a lot of cardiovascular disease. They can have undiagnosed cardiovascular disease, and also if they have CKD, they are predisposed to AKI. So if they develop hypotension, so we have to avoid hypotension in these patients to prevent acute kidney injury. So there are many medication needs dose reduction in CKD, like allopurinol, gabapentin, narcotics, many beta blockers that are renally cleared, digoxin, statins, aminobutyric acid, enoxaparin, methotrexate, and colchicine. So many drugs which we commonly use need dose adjustment. So therefore, it is important that know that the patient is having CKD. So several classes of drugs are renally eliminated. So these drugs need dose adjustment. Consider kidney function and current EGFR when prescribing medication. That's an important aspect. And we have to minimize pill burden as much as possible because the patient with CKD are on many drugs. We should avoid NSAIDs with the patient having CKD. We should avoid dual RAAS blockade, that is combining AC inhibitor and ARB. Any medication which has a more than 30% renal clearance needs a dose adjustment. We should avoid bisphosphonate when the GFR is less than 30, and avoid gadolinium use when the GFR is less than 30. So these are important aspects in medication in CKD. So finally, in conclusion, CKD is one of the major public health problems, and healthcare cost of managing end-stage renal disease is very high. Therefore, prevention and early detection of CKD will be helpful to reduce the burden of end-stage renal disease. The appropriate management of diabetes and hypertension would reduce the burden of CKD. Thank you.
Thank you, Dr. Wazil, for your excellent talk. So if you have any questions, it's time for you to ask. A very important topic, and I know you all know the burden of CKD and most of our health budget. I think significant amount of health budget goes managing CKD. That's why case and part of arranging stroke to as you all involved, we deal with a lot of CKD patients, so we have to have a fair idea how to manage the patient and when to refer, maybe they are admitting for certain procedures, what are the things to be done. So many questions, I'm pretty sure you have.
Thank you very much, Dr. Wazil. It's a very informative lecture. I just want to know whether there is a screening program going on in Sri Lanka, and especially after 60 years of age, people.
there is screening programs done by the CKD prevention unit in the ministry, that is mainly in the CKD-U areas, not in the other areas as far as I know. But it is because when we talk about CKD, many people think of CKD-U, but we forget that the diabetes and the hypertension are the major contributors. I think there is no screening program as such. It's not as a sort of island-wide program. I think, and also it is not very cost-effective. Screen the entire population. It has to be a targeted screening. So it is the all the diabetes, hypertension, the patients with the family history of CKD, and the patients who had glomerular diseases as in childhood, children with childhood UTIs, and the people with urological diseases, stone disease, and other urological diseases, and elderly. So these have to be screened. So it is to be screened. It is a good idea at an MOH level. Screening programs to be developed. It is good. I think some time ago there was a program to screen for diabetes and hypertension, but I'm not aware of CKD. I think it's important to screen for CKD, not the general population, but the people with risk factors. So because otherwise it's not a cost effective the screening program.
Thank you very much. If someone wants to look at screen, what's the test basically your
It has to be both. So you have to have creatinine with the EGFR and urine albumin to creatinine ratio. So these are the two tools that's recommended. So that is the you have to use. So because you can have elevated ACR with normal creatinine, or vice versa, or both can be increased. So you have to use both these, creatinine and albumin to creatinine ratio, so that you can detect the CKD. So in all diabetics and hypertensive and elderly and with a family history of CKD should be screened, and so we can detect early and take appropriate preventive measures for progression.
Thank you very much.
Thank you very much, sir, for the wonderful lecture with a lot of information summarized, and I think it will be very helpful for everybody. The very valuable tips you have given in dealing with CKD patients in the world. One small clarification about the CKD stage 3 and above of NSAID use. Can be used for a very short time, or you recommend like for 3 to 5 days? Can be used in NSAIDs, or it's better to avoid?
I think better to avoid, because when there's a decline in GF, it doesn't happen in everybody, but in some patients it can decline, and it may not reverse completely. So there may be some residual decline in GFR, so that is detrimental. So we can use the other agents to control the pain.
Thank you, sir. Because we see a lot of CKD patients, they use NSAIDs for short duration. So I think it's an important message.
This comes to us as well, because of the, says the NSAIDs are used to renal flow, and then it will reduce the renal pain of the renal colic. So using them for a long time is hazardous to the patient. And so any advice on what other things that we can use other than the, because oral forms are not much available in the market.
Yeah, so but you can use the codeine, paracetamol codeine combination, and tramadol can be used. But I don't know how effective they are. Perhaps in acute colic you can use it, but not as a long term.